Welcome, my dear colleagues. I am Dr. Moustafa Mahmoud. Today, our presentation will cover the diagnosis of obesity. Please don't forget to like, comment, share, and subscribe to my YouTube channel for more video updates. The agenda of our presentation today will cover history, clinical examination, investigations, differential diagnosis, and diagnosis of obesity. History. The history helps to clarify the etiology of obesity, choice of the appropriate therapy, and detection of complications. In most patients, the presentation of obesity is straightforward. Patient's problem is overweight or repeated failure attempts to achieve the desired weight loss. Some patients presented with a history of complications associated with obesity like obesity hypoventilation syndrome or obstructive sleep apnea. In every obese patient, obtain comprehensive history including past medical history, family history, age of obesity onset, dietary habits and eating disorders, physical activity level, mental health status, current medications, smoking or alcohol abuse, previous weight loss attempts and reasons for failure. Clinical examination. In a clinical examination of obese patients, first perform the standard detailed examination required in evaluation of any chronic multisystem disease, paying more attention on the obesity focus findings like acne, hirsutism, acanthosis nigricans, bavalo hump, fat bag distribution, gynecomastia, hepatosplenomegaly, and hypoventilation. Second, measure anthropometric parameters. Although several classifications and definitions for degrees of obesity are accepted, the most widely accepted classifications are those from the World Health Organization based on body mass index. Grade 1, or simply called overweight, when BMI of 25 to 29.9. Grade 2, or commonly called obesity, when BMI of 30 to 39.9. Grade 3, or commonly called severe or morbid obesity, when BMI greater than or equal to 40 kg per square meter. The surgical literature often uses a different classification to recognize particularly the severe obesity. Severe obesity, when BMI greater than 40, morbid obesity, when BMI of 40 to 50, and super obese, when BMI greater than 50 kg per square meter. Waist to hip ratio. Waist hip ratio is the ratio of waist circumference to hip circumference. According to WHO, abdominal obesity is defined as waist hip ratio above than 0.9 for males and above than 0.85 for females. Having waist hip ratio of over 1 may increase the risk of conditions related to obesity, including diabetes and heart disease. Skin fold thickness. The main purpose of skin fold measurements is to estimate the general fatness and the distribution of adipose tissue. The fat is pinched between two-pronged caliper at special sites. 2 to 9 sites are used, such as pectoral skin fold, mid-axillary, suprailiac, abdominal, mid-thigh, triceps, biceps, subscapular, and medial calf skin fold. Usually, subscapular, and triceps skin folds are used. The sum of those calibers are converted by formulas into estimates of body fat and hence the contribution of body fat to total body mass. Neck circumference. Neck circumference equal or greater than 35.5 centimeter in men and equal or greater than 32 centimeter in women should be considered cutoff point for overweight or obesity. Also, neck circumference greater than 43 centimeter for men and 39 centimeter for women associated with increased risk of obstructive sleep apnea. Waist circumference. Waist circumference is a measure of abdominal fat level. The cut-off points of the waist circumference vary between racial and ethnic groups. However, for men, a waist circumference below 94 centimeter is low risk. 94 to 102 centimeter is high risk, and more than 102 centimeter is very high risk. For women, below 80 centimeter is low risk, 80 to 88 centimeter is high risk, and more than 88 centimeter is very high risk. Investigations. The first type of investigations in obese patients are the standard laboratory studies, like CBC, basic metabolic panel, renal function, liver functions, lipid profile, hemoglobin A1C, TSH, urine analysis. Other studies like ECG and sleep studies can be done for evaluating associated comorbidities. The second type of investigations in obese patients are used to assess fat degree and distribution, like dual energy X-ray absorptiometry or DEXA scan, ultrasonography, CT scanning, and MRI. Total dual energy X-ray absorptiometry or DEXA scan can be used to assess fat tissue amount and distribution. The fat amount assessment can be measured as percentage fat mass, which equal fat mass in kilogram divided by total mass in kilogram multiplied by 100, or fat mass index in kilogram per square meter, which equals fat mass in kilogram divided by height in square meter. Magnetic resonance imaging and computed tomography scanning are considered the standard techniques for measuring subcutaneous adipose tissue and visceral adipose tissue. After diagnosis of obesity, obese patients should be risk stratified based on morbidity and health risk profile. The Edmonton Obesity Staging System, one of the most commonly used systems that classifies obese individuals into 5 stages. Stage 0, no apparent obesity-related risk factors, no physical symptoms, no psychopathology, no functional limitation and or impairment of well-being. Stage 1, presence of obesity-related subclinical risk factors, mild physical symptoms, mild psychopathology, mild functional limitation and or impairment of well-being. Examples of stage 1 in obese patient, the presence of pre-hypertension or pre-diabetes. Stage 2, presence of established obesity-related chronic disease, moderate limitations in activity of daily living and or well-being. Examples of stage 2 in obese patients: the presence of established hypertension, established diabetes, and sleep apnea. Stage 3, established and organ damage, significant psychopathology, significant functional limitations, and or impairment of well-being. Example for stage 3 in obese patients: those with MI or stroke. Stage 4, severe, potentially end-stage disabilities from obesity-related chronic disease, disabling psychopathology, severe functional limitations, and or impairment of well-being. The Edmonton Obesity Staging System considers metabolic, physical, and psychological parameters in order to determine the optimal obesity treatment. Differential diagnosis of obesity. Obesity should be differentiated from several conditions like adipose dolorosa, which is characterized by multiple painful lipomas affecting the proximal extremities, trunk, and buttocks. Acromegaly, which is characterized by frontal bossing, acral enlargement, visual defects, macroglacia, prognathism, and elevated growth hormone levels. Generalized lipodystrophy, which is characterized by loss of the adipose tissue and extreme muscularity. Ascites, which is characterized by fluid collection within the abdominal cavity. Hypothyroidism, which is characterized by coarse and brittle hair, dull facial expressions, macroglacia, bradycardia, and TSH levels are elevated while free T4 levels are low. Diagnosis of obesity. When reaching the diagnosis for obesity, it is advisable to comment on the class of obesity using the body mass index, percentage of body fat, which can be indirectly estimated using Durenberg equation as follows: 1.2 multiplied by body mass index plus 0.23 multiplied by age minus 10.8 multiplied by 6 minus 5.4, where the age in years and 6 designated as 1 for males and 0 for females. Finally, the stage of obesity using the Edmonton Obesity Staging System. And here is an example: female patient, class 3 obesity, 36 fat percentage, stage 1 obesity. At the end of my presentation, thank you. See you in the next lecture about treatment of obesity. Till we meet again, goodbye.